But right now the goal is get back on your feet, recover without an infection, with all your soft tissues, fully healed, solid bone, and then ligament reconstruction, and then see where you're at. I'm Doc Faisal, orthopedic surgeon with Move Smarter Health. We are sponsored by an educational grant from Kinesi Movement. I love sports, I love talking about injuries, I take care of shoulder and knee injuries, and I operate and treat on them, and please consider this an educational, informative video only. Here we go. All right, the Olympics are over, and I know. Lindsey Vonn, another injury, very unfortunate, but I feel like this is almost becoming like the Lindsey Vonn show, which would be great. But the unfortunate part is we're talking about another Lindsey Vonn injury. And I know we talked about it the last time, the complex tibia fracture, a lot more information has come out, and unfortunately it's as bad as I suspected. I sort of gave the worst case scenario, and that was the fasciotomies, the swelling, the significant injuries, the open wound, the open fracture, did require emergency fasciotomies. That's what you read out there. Now, basically what happens is, on top of all of this, we talked about it, you have soft tissue envelope. The envelope is, you have the skin, then you have a little bit of fat, then fascia, and the fascia forms little pockets of plastic. Think about it like a bunch of plastic bags that are watertight. They're not quite watertight, but watertight enough that if you get something bleeding or damage, then that can blow up and create pressure. That pressure can become so severe that can actually cause necrosis. Necrosis is tissue death. So that necrosis you want to avoid. So that means high energy injury, even if it's an open fracture, you think, oh, it's an open fracture, it's been decompressed. So I know every resident out there already piped that out, that absolutely you get an open fracture, it doesn't necessarily rule out the need for compartment syndrome fasciotomies. And there are superficial and deep compartments. So if you have a significant injury, which she did, we know that it's a Schatzker 6. Now that means the worst of the tibial plateau fractures. And it's like proximal tibia all the way up to the articular surface. And we talked about that as well, that if it involves the articular surface, the tibial plateau, you can see the image over there. There's going to be a little box on one of these sides, this side. And so that really shows it. And I'm going to talk about the second image. That's an image I blew up of the tibial plateau on the lateral side. So you can see it over there. And then I'll go into it in more detail. Sorry, it's here. It's also there. It's both places. It's everywhere. The point being that we have a complex fracture, multiple fragments, comminuted. It had to have an external fixator. We talked about that as well. That's confirmed. Many of you that are interested in her injuries have seen her posts. She showed herself in the hospital bed with the fixator on. There were dressing and wounds around there which clearly appear to be related to possible fasciotomies. That has now been confirmed. So she had the fasciotomies. As far as we know, there are no nerve and vessel injuries, but we don't know for certain. Only so much information has been actually released out there. Now, once you do fasciotomies, you have to have a delayed wound closure because you have to open it, allow it to decompress. You can put different dressings on it. It all depends on, in the US, often we times use a wound vac type of treatment. Sometimes, what we used to do, and sometimes we still do to avoid infection, is you wrap it up with a sterile, transparent bandage, and you may or may not put antibiotic beads on it. You may or may not flush it with antibiotic solution, drips into that area with a suction going out. There's all sorts of different types of treatments for that. And in some cases, you just leave it open with wound dressings, wet to dry, where you have saline, moist saline, less moist saline, and dry dressing on top. We kind of have moved away from that in the US just because you want it sterile, and you take them back into the OR 24, 48, 72, depending. Everyone has their own routine and practice, checking the wound, checking the neurovascular function, nerve and vessel. Now, sometimes, and depending on whether you're a medic or ski patrol or ambulance, sometimes you call it color sensation motion, CSM. Different terminology. Neurovascular status, very specific. We use that. Nerve, vessel, injury, also color sensation motion. Those are all important in the first responder reaction to what's going on in the leg. Okay? And so she got helicoptered out, she got treated, and she had emergency surgery. So where is she now? Now, she had the fixator and the fasciotomies. Now, over a period of a few days, eventually, once it's stabilized, the fasciotomies are complete, neurovascular status. Now, I assume that if she had a neurovascular injury, it's been addressed. The reason is you don't want to try and put the plates in if you have a vessel injury. So if you had a ruptured vessel, the fixator would still have been on there because you want it to be stabilized. Because at some point, the vascular surgeon would have had to go in and put a graft and stabilize it, allow that to heal, and then you can do the secondary surgery or tertiary surgery. I mean, she's into her, I think it's all past her 6th surgery, I think, if I recall correctly, in terms of what we do know. Again, this is what we know based on what Lindsey Vonn, her physician, and the team have provided information on in terms of what's available out there. I don't have specific health record information on Lindsey Vonn. I'm not her treating surgeon. Okay, so we're talking about this in the context of her injury. Pretty significant. Now, she has recovered from incredible injuries. So but I have no doubt that she'll recover from this. I know that there was some chatter on the social media about is she going to lose her leg and all sorts of things, but we're not going to go down that path. If you have a major neurovascular injury and loss of tissue, that may happen with any severe injury as a possibility. You know, let's just put a pin on it. Far away. Let's wish the best, blessings and prayers out for Lindsey Vonn and her family and her leg to recover from this. So continuing back, the plateau fracture has been addressed, it's been treated, you can see it. Now, let's take a closer look at it. So up here, what you see is the full length of the tibial plateau fracture, and I zoomed into an area in the lateral articular plateau. So that is on the outside part of the tibial articular surface. And you see 3 lines, red, green, blue? Yes, red, green, and blue. So what they appear to be, and now again, this is not intended to be a criticism of the quality of surgery at all. This is the nature of severe tibial plateau fractures that happen in any patient in the worst of, she had the worst of tibial plateau fractures. I mean, the only thing worse than this would have been a gunshot wound that destroyed the tibia and blown out pieces of her bone that were either no longer inside her leg or were blown to smithereens into dust. So that would have been the worst case scenario, or an IED blast. I've treated both of those situations, and it's really sad when you have these patients come in. I've treated military patients as vets who come back and they have these IED blasts, they've lost bone, they've lost nerve and vessel injury. I've also treated patients with major gunshot wounds, and you have sometimes no choice. You got to take it out. You can't leave unvascularized bone inside an open wound that could be a source of infection, because essentially what you're leaving is a material that's prone to infection if it doesn't have a blood supply. Now, we try and preserve the articular margin, articular surface as much as we can, okay? So let's just, again, put that aside. That's the worst of the worst. But in terms of the fragmentation and how comminuted the tibial plateau is, yes, it's a pretty bad tibial plateau fracture to have 3 plates. Now, we only have the one view of the AP, so we don't have the lateral view. So it appears that She has a plate on the lateral side and the medial side, and I suspect there's one on the posteromedial side to stabilize the fragment. So you essentially have a 3-column support for the tibial plateau, which you often need in a Schatzker-6 type of fracture, okay? I'm not gonna go into the classification. You can look that up, and if Joey feels like looking one up, Schatzker-6 classification's right here. Schatzker-6 is the worst of the comminution. So that means both condyles, both sides, medial and lateral, with articular damage, split apart and extending down from the articular metaphysis, and actually in her case, you can almost see that it's into the upper part of the diaphysis. The diaphysis is the middle long tubular cylinder of bone. The metaphysis is where it curves out, and then the articular surface is the top. So again, the blown up, zoomed out view is not a criticism. I mean, these are difficult fractures to treat, okay? The surgeons did an incredible job of putting this back together. Now, if I were to zoom in, and again, we only have one view, we don't have a CT scan, which would be a 3-dimensional reconstruction, and a multi-view evaluation, we have an AP view. However, you can see the shadows of what appears to be different articular margins. The articular lines of the plateaus are at different levels. Now, if you look at the medial side on the inside, you actually see 2 smooth lines. Now, if you were to imagine, I'll use my glasses as imagine. This is the articular plateau, medial side and lateral side. Now, if you tilt it just a little bit, do you see how you see an oval? If you have it perfectly, you can see the line. Now, it's not a perfect AP because it's actually a tibia view. It's not just focused on the articular margin. And that's one of the things, I'm sure they got better x-rays, and they're going to get a post-operative CT scan to look at the articular margins. She may or may not need an arthroscopy and reconstruction of the articular surface. Those are, again, things we don't know that she needs. Those are always possibilities, and those are things to consider. She may have actually had a dry scope or a wet scope where you look in while you're doing the surgery to elevate the margins as best you can. Now, you cannot put bone graft or calcium phosphates or some type of a bone that's not native to elevate the fragments right away because it's an open fracture. She had a fasciotomy. She's going to have more surgery. But later, hopefully within a couple of weeks, you can go in and see if you can add, make sure she's not infected, and then you can add and elevate the articular margins. So if you look at it this way, you see an oval on the inside, but the oval is broken multiple levels. So you see 3 separate lines that you can see at least on the view that we have that suggests that maybe her articular margins aren't perfect. Now, you can never, there are great surgeons out there, much better surgeons even than I could possibly think I am, because there are surgeons that treat this all the time in trauma centers. And I worked in a trauma centers, and when you do it all the time, you get really good at it. Now, the articular margins are separated. If they can be aligned, great. But sometimes even like a millimeter or within a couple of millimeters might be sometimes the best you can get. Sometimes it's fragmented such that you could actually make it worse, right? So what's the rule? 1, which we often know, less is more. So sometimes doing less may actually be better for you because you can always make it worse. So what's the enemy of good? I heard you guys out there. That was an Arkansas resident who said it first. Better. The enemy of good is better, okay? This is biological tissue that's been damaged. You can always make it worse if you try and get, like as surgeons, we're all OCD. We want to make it perfect. But sometimes when you try and manipulate the fragments too much, you could actually make it worse. It could fragment even more. It could fracture. It could actually, you're trying to elevate it up, and all of a sudden one nice chunk suddenly cracks. And you then have 2 or 3 chunks to deal with. So you've actually made it worse. So that's another challenge with biological fixation, is that you may never make it perfect. Now, we don't have the ability of pouring a new layer of cartilage. It'd be great, Like someone should, develop that. I know there are people trying to develop artificial cartilage. It hasn't quite happened yet. Nothing can replace native hyaline articular cartilage yet. So we can't just pour in some more cartilage and smoothen it out just like you see concrete being poured. We don't have that ability yet. So right now we can just try and elevate them as best we can. We put bone struts and fixation to try and keep it elevated. And then the next step is it's a balance, right? You want to move the knee, but you don't want to move it too quickly. Now, this is the same knee that she had the ACL tear in. So that adds another level of complexity. So she has instability. Now she's got a fracture. Did she blow out her PCL? Did she blow out her MCL, LCL? We don't know. Hopefully, the energy went through the tibia and no other ligaments were injured other than what we know already as the ACL, okay? So in the end, hopefully, let's assume, we don't want to assume when we're treating a patient, but since we don't know, it's more like positive energy reinforcement, hoping that she gets better with less injuries. At some point, you have to deal with the ACL. But you can't treat a ligament injury if you don't have a solid foundation of bone that's healed. So you need the bone to heal, you need her muscles to recover, and you need her to be able to be weight bearing for a period of time before you go in and treat the ACL. Now, everyone can have different theories about this. I'm not saying what I recommend is the best. What I'm saying is that ideally, if this were my patient, I would say recover from your tibia fracture, let you get a nice solid column of bone without any infections, and if there was an infection, have it treated. If you have a nerve injury, let's make sure we identify it, see if it needs treatment. Sometimes the common things, because you see it's on her lateral plateau. And I heard you, Chicago. So what did that Chicago resident say? Right around the tibial plateau, the common peroneal nerve comes here. So did she injure the common peroneal nerve? If that's the case, does she have a foot drop? If she has a foot drop, that needs to be treated. So we don't know any of that. I'm not saying she has any nerve injuries or vessel injuries. However, there are other complications that can happen associated with this. And it may not happen right away. It could happen later. Like she may have limited function only because of a contusion of the nerve. You know, you can have a neuropraxia, or you can have an axonotmesis. You can have complete rupture of the nerve, or you could just have bruising of the nerve. And so it can take some time to recover. And if it doesn't recover, what's the status of the nerve or function? So those are other things to consider. And then once the bone and tissues are healed and you have a healed envelope, wounds are closed, solid bone that you can actually utilize, then you go in and reconstruct the ACL and or other ligaments that are there. Questions?
So bone takes X amount of time to heal.
Yeah.
Is it different because there's 400 bone breaks?
Oh, yeah. So, great question. It actually came from Joey, you know. I shouldn't be that surprised. Yeah, it was kind of surprising. So the question was, will it affect the healing? Well, so metaphyseal bone, which is the upper part into the articular surface, that takes about 6 to 8 weeks to heal in a closed fracture, assuming there are no other wounds, injuries, infections, or complications, okay? And it's stable. Now, in a unstable comminuted fracture that extends down into the diaphysis, could it take 6 weeks? Well, maybe. It could take 8 to 12 weeks. Why? Well, when you have the articular margins, you have joint fluid that's maybe communicating with the metaphyseal bone. So it could interfere with the healing. And also some of those bone fragments could go through what's called micromotion. Micromotion is our way of describing that it's not macromotion, meaning you look at it on X-ray, it's stable, but deep inside, if you look at it from a nanoscope, millimeter scope, there may be some micromotion happening in the bone that can limit the healing and the articular cartilage. And when the articular cartilage heals, it's not hyaline cartilage, it's fibrous cartilage. So the articular cartilage, what can happen is you can have a gap If it's too big a gap, it can't bridge across that. If it's close enough, and that number, is it 1 millimeter, is it 2 millimeters, you could have an entire academic discussion about that. So ideally, we don't want more than a 2 millimeter gap. I think you try and get within a millimeter, but again, less is more. Better, the enemy of good is better, right? So you want to get it as close, and if you can, you have it lined up, you can get fibrous cartilage going along there. Think of potholes on asphalt pavement that's been run over. What do? We don't just layer out new asphalt. We actually pour in some tar and asphalt and stamp it down and cover it. But it's not perfect. You can feel it when you're driving. It's never smooth. So that's kind of, imagine that as fibrous cartilage in an area where there's gaps or fractures forming. So it's never going to be as smooth as if you kept the meniscus and the articular cartilage, which brings up, the meniscus. So what about her meniscus? Was her meniscus damaged or torn? Now, even if you have a bad fracture, the meniscus could be fully intact. It could be attached to the peripheral articular margin and the joint space. It could be attached to the capsule. So it may have good supply. But the question is, in this fracture, are the tibial spines affected? Based on the x-rays, there's no screw or there's no fixation in the area of the tibial spine, so we don't know how bad it was. This is what we have right now. So maybe with her in extension, the tibial spine, the main central column may have been intact. It's the outer, the bicondylar components that may not have been intact. We don't know all that. So if her tibial spines were intact and the menisci were attached close to the tibial spines on the inside of the knee, and on the periphery they're attached to the articular margin where the joint capsule is, if that's all intact, great. And when you, and I know the other question, I know some of the orthopedic residents and surgeons out there are all going to be throwing out comments out there. I'm talking as if I've got millions of people watching this. Meanwhile, it's like crickets, right? No, I'm kidding. So anyway, so you've got all that. Now you can elevate the cartilage above and you can work on the tibial plateau. And sometimes, and this is often what I have done in the past, I don't treat fractures like this anymore. I don't operate on trauma patients anymore. But when I did, I would put a scope in, and dry versus wet means whether or not you put saline in. In a bad fracture like this, I'll actually go dry. So that means I'm putting a scope in, and I just put a little bit of fluid, just enough to clear up the space, but you don't want to fill it up because then you're increasing the tissue pressure and swelling. So you want to avoid that in complex fractures like this. So you put the dry scope in, you're looking, and you can actually see all the articular margins. So you look in with the scope from above, or even you could, if she has a meniscus tear and it's open, you can elevate it up and put a dry scope in to get a micromillimeter view of it. But regardless of how you do, you would look at the articular surface, you see how the fragments lie, and then as you put in the fixation and as you stabilize or elevate, then you can line up the articular surface. Takes a little bit longer, a little more complex. You're definitely not going to do that right away in this type of fracture, because emergency surgery, fasciotomies, fixation, you just want things stabilized and lined up because you're gonna have to come back another day, and that's what happened. So at some point, will she need that articular surface treated? I don't know. Again, this is one view, an AP view, slightly oblique. It's not a perfect articular line. We don't have the CT scan, so don't misinterpret what I'm saying that it's not a good surgery. Absolutely not. This is a great result from a complex fracture to stabilize it right away. The question is, can you do anything about the articular margin? And only the surgeon that operated on her knows that, because he was in there and he says, there were so many different articular fragments. This was the best that can possibly be done. And I put a scope in, I tried to elevate, but it was actually going to make it worse if I tried. Sometimes the only time we'll try and push it a little bit more is if, say, one of the articular margins, like if you're like this, great. Close enough, right? Maybe you try and compress it, but then it can flip up like that. If it's flipped up, that's when you try and correct it. Or if it's too big a gap. definitely we know that if it's, we try and aim for that less than 2 millimeters. But the other situation is if it's depressed like this. Now, it does look on the view that one of the lines is a little bit lower, and sometimes it could be a die punch fracture. Die punch fracture, we all know, not we all know, I don't want to say that, but if you're an engineer or a mechanic, or you work on wood and metal, you know what a die punch is, or even a jewelry maker, right? You basically have a rod, you hammer it in, and you create a little divot. Think of it like a golf ball landing on a clean green. It creates a divot. Well, one of those articular margin could be a little divot where it drops down. So that hole is formed, and the other articular margin is there. So you want to elevate that up and fill in with bone graft or calcium phosphate or some type of material to help regenerate. There's so many different types of biologic and non-biologic products and demineralized bone matrix. Sometimes you can use silk protein, and sometimes you can use various types of PLLA or other types of plastics out there. They're absorbable materials. They tend to stay for a decent amount of time, so allow you to have these elevated. But you don't want to put them in right away. I mean, you have absorbable screws. Could you use that? But you don't want to use that right away because it was an open fracture, multiple surgeries. You don't want to get infected. Okay? So, what do we do with this? Right now, this is the most information I have right now. I hope that she gets better. And I'm just glad that her surgeon was there and had the ability to operate with the Italian team. Now, this is something that, is a pretty amazing privilege that other countries offer that we don't necessarily have in the US. In Italy, by emergency measures, a surgeon that is part of the Olympic team as the treating surgeon for the athlete in international events was allowed to get emergency privileges in Italy, not just in that state, in that hospital, in Italy to operate. In the US, that wouldn't have been possible. Like in the US, you can do splinting, taping, those kind of things, but you can't actually get privileges, emergency at this level in a hospital. Now, I could be wrong, but as far as I'm aware, the credentialing system in the hospital doesn't allow for that to happen in an emergency situation. It would be the treating surgeon at that facility where the patient arrives that allows that. So that was one wonderful aspect of the Italian system that allowed a US surgeon who's the treating surgeon for Lindsey Vonn to actually operate. So that was a great benefit that Lindsey Vonn had, that her own surgeon was able to be there and operate and do the treatment and participate in the surgery. And so that's wonderful news. I think it's great that she had her own surgeon there, and I think that's a benefit, and I definitely give the kudos out to Italy and the Italian team and the US surgeon and everyone that was involved in her care. And it's not a criticism of the US system, but that is something we need to be aware of, is that the foreign surgeons would not necessarily have had that same privilege to operate on their athletes if a similar injury happened to their athlete in the US. And so I think it's great that our surgeon from the US was there. I definitely, prayers and blessings out for Lindsey Vonn to have a smooth recovery. I know there was an athlete who had previously had a ACL tear, and then she won gold. That's great. I hope, and I know Lindsey Vonn is a highly decorated athlete. She has incredible grit. Will she come back? I hope so. I don't know. I think right now that's not what I don't think she's thinking about. I don't want to say, but right now the goal is get back on your feet, recover without an infection, with all your soft tissues, fully healed, solid bone, and then ligament reconstruction, and then see where you're at. I mean, she's an incredible athlete. She's got incredible grit. If anyone's going to recover from this, it's Lindsey Vonn. See you next time.